All right, I'd like to go ahead and get started. We may have some join us, but it's 5 after the hour. This is Brian Mittman, and I'm pleased and have the honor of introducing our final keynote plenary speaker, John Øvretveit. I won't provide a detailed bio. It's available on the conference website, but just to point out two unique and important features that John offers, one of which is his high levels of interest and expertise and contributions both to the improvement science literature as well as implementation science. And most of us tend to focus on only one or the other, realize that there are many benefits to be had by better integration and sharing. And John is one of the few who can actually help with that boundary spanning with, as I said, expertise in both. But the other perhaps more important feature is the fact that John now has a split appointment with part of his work continuing to focus on research in science and generalizable knowledge, but part of his salary support comes from health system and policy practice, which again gives him a unique perspective and ability to provide insight. So John, without any further ado, as they say, over to you.
Thank you very much, Brian, and welcome everyone. And I'm going to try and keep this lively to keep us all awake. This is an invitation to join in developing rapid implementation research. And some of us think that implementation research has much to offer to services to help them make changes to respond to emergencies, both this continuing emergency, it's not over yet, and to new ones, because there will be further infectious outbreaks in the coming years. And I think we've been woken up to that. So we're working to help our services prepare for the winter resurgence and the health consequences of this crisis over the winter and the next 18 months or so. And I'll use the project that we started in March to give an example and share the challenges that we faced and some of our resolutions and what we learned about implementation knowledge and research methods. So the subject is implementing emergency management of all the primary and community healthcare services in the Stockholm region. And first I'll give a bit of background, and then I'm going to share the story of our project so far. And then we can look at the implications for implementation, research, and practice. So the first tested positive test for SARS-CoV-2 was 31st of January. On the 11th of March, the first positive COVID death was registered, the same day that WHO declared a pandemic. And in early March, we started a research project into the implementation responses to the pandemic. Now, as Brian said, my job is 50% a government employee of Region Stockholm Healthcare and 50% employed by the Karolinska Medical University. And we had been doing a 3-year study on management decentralization, and I wasn't about to sit on the sidelines and watch all my clinical colleagues get dug in when I felt that implementation science had something to offer. So what I did is I put together this action research, and I'm going to tell you how we tried to do rapid implementation research that was relevant to decision makers to help them implement changes, and also how we did it with limited resources, because our team was 7 part-time and none of us were funded, and there's more on that story later. It's not the best way to do this sort of work, but I think we did something useful that I'll talk to you about. So we started on the 15th of March, and we're able to fast track the ethics approval that is usually an arcane process here in Sweden. Within 10 days, we got agreement for that. And the first challenge that we faced was how to define or focus the project for something which is feasible and useful. How could we make use of implementation science and understanding, but also deliver something quickly that was useful to managers and others? So the concepts that helped us sort out and think this through was the very simple one between the intervention, which I've found, if I call, this is the new better way that we need to introduce. We don't get in squabbles about how strong the evidence is in supporting it. I often put new better way, bracket possibly, that's needed. And that's different from how the new better way is implemented, what we actually do to enable people to take up this in everyday practice and do it consistently. Good example here is a treatment, the CPAP treatment, which really was hardly used at all. And this was a sudden, without a lot of evidence, and everywhere from Italy, US, Sweden, UK, we were able to use this to avoid putting people on ventilators, which isn't the best way. Another thing is the obvious WMD, wash, mask, and distance. And a third one is reorganizing service delivery. Here we've got special test tents that you're probably familiar with in other countries. Now, what was the purpose of the project? Well, research informed implementation, and we did that through weekly reports that I'll talk to you about, and also making recommendations. I have to deliver a report in August about what we learned from this project for implementing winter responses quickly when that may be needed. And of course, the dual aim is scientific knowledge as well. So this isn't just an analytics or a consultancy project, but the aim is to contribute to scientific knowledge. And in particular, scientific knowledge about how to implement an emergency response to infectious disease outbreaks. There's a lot in the public health literature about this, but not about implementation and service delivery, implementing service delivery changes. And I can talk about the gaps in the literature there. So I think this is a Venn diagram overlap between implementation science and emergency management and public health. I'll come back to that as a kind of an important subspecialty that I think we could develop. 4 questions. How was emergency management implemented? What worked well? What do we do better next time? And what are the recommendations for the winter? So the first challenge in our project was, well, how are we going to describe the intervention? What exactly is the intervention before we get into the implementation? Well, one part of it was this emergency management structure, because we were instructed by the regional government to set up our system is a NATO emergency response, and the emergency management group has logistics and informatics and a whole range of others that are not usually so prominent in the ordinary operational management. So this worked alongside and instructed the ordinary operations management. On the 20th of March, we were instructed to coordinate and lead all of the non-acute hospital services in Stockholm region. And 70% of our primary healthcare centers are private. And then we've got our social care municipalities, and more on that later. How do we collect the data? Well, what I did was put together weekly surveys that all of our heads of units, 110 heads of units filled in. It took 15 minutes to fill it in, 9 questions. And the questions were informed by implementation research in very simple way. Like context was to do with what helped and hindered you to implement it. And that was after what were the direct instructions and direct changes you had to make. We did interviews with all of the emergency management team, which was about 18 different people. And then there's documents. We have an emergency plan for primary health care. And we used already collected quantitative data that I'll talk to you about later. We and the public health were under high scrutiny from the media. And actually, this is a very interesting thing. So I'll come back to that later. But what I'm talking about at the moment is how we use implementation science concepts to structure and focus the project in the early days of setting it up. So if I can move on to the next slide. So the question then is, if we've got the intervention and implementation, what would be the context? Well, basically it's everything that's not the emergency management structure. And this is the government and local laws and the context of the rising rates of infection and deaths. That was, how shall I put it, a motivating force for the everyone to all hands on deck. And also, like I said, the media scrutiny. What this does is shows some of the international media scrutiny that we were under also. So there was a bit of the capital city, Sweden. We mustn't mess this up. And that's other documents on this. So the question is, what would be the outcome of implementation? Well, the long-term ones are obviously to do with what would show success in implementing. Well, the long-term ones are health, mortality, infection, so on and so forth. But remember, we're looking at implementation outcomes. And here we're looking at if the implementation and operation of emergency management was successful, what would we actually observe? Well, some example would be that the information and guidance that we issue to our heads of services meet their needs. Also that they have the resources and they're able to make and that changes that are necessary, for example, in staffing and IT and personal protective equipment and materials, that actually is delivered. Now, we got the data on the outcomes of implementation from most of it from the weekly surveys, but also a bit from the other records. And what I'm going to do is give you an example of this is a method of implementation. This is volunteers delivering PPE. This is in end of March, early April. So what are the outcomes? Well, the PPE and supplies. Now, one of the implementations that we did was we couldn't get supplies from the national and the region stockpiles. And we just cut loose and formed a purchasing and logistics unit with the hospital, with the Karolinska Hospital across the road. And part of what helped to do this was we knew folks from Scania who had Scania partnership that had built the hospital and were finishing it off and volunteered to help us because they have a purchasing and logistics. They're known internationally, and they were able to source materials very quickly and fly it in and bring it in using their logistics. And we stored it across the road in, well, no, actually it was in our, downstairs in our offices on floor 4. There's big storage there. And then the issue is distribution. Actually, that's Sarah, our director of operations, and some of the Scania staff. This is downstairs where we're unpacking and then repacking for distribution using volunteers and everyone, all hands on deck there. Okay, one of the other outcomes was the transition quickly to digital care contacts. And what this shows is for psychiatry, but it's also for all primary healthcare, all TDOPIC there, is one outcome is over 6 weeks, we increased for psychiatry 175% of digital contacts and over 1,000% within 6 weeks in primary care. And one of the big issues there is the issues about equality and digital disparities. And we're still following up whether minority and other ethnic groups and low-income folks did have access to that. Sweden, most people have 2 cell phones in Sweden, but we need to check this. The second challenge is that this is an evolving crisis. In many ways, it's only just beginning. How are we going to depict, how are we going to collect data about this constantly changing dynamic situation and the changing approaches that we took to implementing different things at different times over the last 5 months? There were daily changes. We need to document these and work out a way to present it. So when you're doing an emergency and an evolving situation, it's not a one-off emergency, but it's an evolving crisis. One of the issues here is how do you actually convey that or explain it and then relate that to the different outcomes at different times? Now, let me show you some of the frameworks that we looked at to try and help think this through. Obviously, the Chambers dynamic model is a good one, but it's too abstract. Saldina is quite good as well. That's the Chambers one that some of you may have seen. It's a good explanation of the dynamism, but it didn't help us in terms of how we present our reports and research. Then we've got the stages of implementation. Again, this is not really suited for an emergency, an evolving emergency situation. Other implementation concepts that we did find useful were the MISHI and the TDF on MISHI that some of you may have heard about in the other sessions, and also the PAL one. Now, this here is to invite you to think about whether this method for social distancing in primary care schools, is that an intervention or an implementation method? Is that an example of where that distinction breaks down? Anyway, I'll leave you with that one. Now, what helped us? Well, we simply chunked it into phases. There was the starting the emergency management, then there was the evolving response, where we consolidated and developed this new, basically 2-system health service, COVID and everything else in our primary healthcare. And then what we've been working on now is the transitioning phase. And what we have to do in August and onwards is catch up on delayed and avoided illnesses, chronic illnesses, mental health, and prepare for the winter. And there's more on that. This was a couple of weeks ago. Notice no face masks, but I think they earned it. They were up in the ICU at the New Karolinska Hospital and came out. The third challenge is data for management decisions, and I need to go very quickly now to have questions. Providing data, I think, is part of implementation if you're doing a rapid implementation project. And what we had was the national and other data was basically out of date, and there were big discrepancies with our local daily reports, our local databases. So what we actually did was combine different databases. It was a bit of a string and sellotape endeavor, which we're having to make much more robust now for the winter to provide this data. And we use the Penn University Open System prediction model, but we're able to modify the algorithms using the actual real data. And this is some of the data that we got and reported. This one, actually, we reported to the region, and this was an example of political data. Let me explain. On the left, you've got all of the acute care hospital daily. These are the number of patients in all of the hospitals on a daily basis with COVID-19. On the right, you've got the number of patients being treated by primary and other care who are not quite acute yet, but are being closely monitored in different ways by our services, ready to transfer to the hospital if needed. And the argument here was those on the right are keeping the hospitals from being totally overwhelmed. So this was the front line of the COVID treatment and approach for those serious patients, but not sufficiently serious that needing admitted. And that is a key thing. The second thing is, I'm really just showing you the most important ones. What this shows is the elder care in patients cared for. And this is for residential homes, and it's also in our few geriatric community-based hospitals. And it shows that 40% more of patients are being cared for per day outside of hospitals than actually in the acute care, which is the blue one. Now, this is really the most sobering and tragic graph that I've ever had to present in my whole career. What this shows here, and this is data that we pulled off the municipality databases on a daily basis. Well, every 2 days is more accurate. And what this shows is the number of people in or from older residential care homes that are contracted by the municipality, and the total numbers mortality, either originating, and this was due to fast infection in a few care homes. And I'll come back to that later. And the issue here is we know we have very, very, very good solid evidence from CDC and elsewhere about how to prevent infection spread in care homes. It's purely an implementation issue. We had the money, staff were off, but you can redeploy the staff. That's implementation, and I can speak about that later. We found of value is a version of the PDSA rapid learning cycle. The difference from PDSA is the effort that you put into defining the problem, and then you would decide the data that would indicate the problem solved, and then you get on to design and implementing the solution, the implementation being the important thing there. And then you review the data and revise your solution and repeat as the situation changes. We've found that model particularly useful in our research, and many of the people we're working with found it very useful. So what I've been talking about is the kind of research we did, and what it involved was presenting data and also projections about the incoming demands that we could expect. This really did inform the decisions. Also, the weekly surveys from the managers about what they were implementing and what was helping and hindering them implementing the changes. And we'll be able to use this data later on for the more sophisticated evaluation that we're doing. So a lot of this was simply to make sure we had the data, and we haven't properly analyzed it in a very detailed way for publications, although we've got 4 publications in the pipeline already that are going in. The big issue is to do with attribution in some of these in terms of this management structure. So you see, really one of the important things that I'm saying here is really, so on the main points is, I'm talking about implementing emergency management. I'm talking about doing this for non-acute healthcare where there's little research. And what I'm talking about is rapid research where you have access, quick access to the data, and the data is being used, and you can give feedback to improve the implementation as it actually happens. And that is, I don't care whether you call it implementation science, but it uses implementation science, and it's what was needed. Now, what also helped us, has to be said, is the long-running partnership, the trust that we had, the fact that myself, I had a 50-50 joint appointment, and the fact that we were continually providing reports that were of value to the services. So people were prepared to give us time to work with us and answer all of these questions. So to finish off, implications. We found the methods were limited for this kind of research, and also that there were useful ideas in implementation science. I think some of the most important were to do with context, how to break down context. And we could not have focused the project to decide which data to collect without that. But this isn't a one-off emergency. It's not a long-term implementation thing. It's a dynamic, evolving implementation of non-evidence-based changes. And I think there's tremendous opportunities to develop a rapid implementation response science. And in fact, a group of us internationally are working on this right now, because we realize how important this is going to be in the winter. And I can talk about that more to be of use then. So, comments and questions. What were your experience with implementation research for a COVID response? Are you going to be doing retrospective observation, or were any of you, are any of you collecting data now with that in mind? And are you able to feed back those data as it happens? Do we need a rapid implementation science, or is this just further subspecialties? And what are your views about the best way forward? I'll stop my screen sharing. I don't know what's going to show up there, and I'm all ears for comments and feedback.
John, thank you. This was a very powerful and valuable description of what we're now taking to calling in the States, as you know, embedded research, research that aims to simultaneously contribute to near-term improvements as well as science. So there are some questions. I'd like to first turn to Adam Shoesmith, who has a question about political context. Adam, if your mic is open, if you could ask your question.
Sorry, I can't find him. I'm trying to find him. He's not.
I'll pose the question, then Adam, you can ask any follow-up. So John, the question is if you could talk about the impact of the political context on implementation. And I'll point out that we only have about 10 minutes, so I think if you could provide partial answers, perhaps that will allow us to get to more of the questions.
I think there are, can you hear me all right?
Yes, fine.
I think there are two things of interest. We have to separate the public health aspect from what we did in service delivery in primary and community healthcare. The context was that the no lockdown, but also something very special in Sweden. The constitution means that the government cannot restrict freedom of movement. The second thing is that our public health agency, our national authority, basically the government has a very weak role, and it's the public health agency that issues the guidance and the instructions and is generally listened to by the public. The public have a higher trust in the public health agency than in the government. And I won't go into the details of that. So it's within that context that some of us from I mean, I've worked 15 years in public health, and I was thinking this is going to be a total disaster. It's going to be a nightmare. I was surprised. I was wrong. But 22 of our professors wrote a very stiff, unusually stiff for Sweden letter saying, you must be crazy doing this, having this open approach. So one hypothesis, and I'm of course biased, is that our fast and effective public health and community health response was able to help people stay at home, monitor them, and people were not showing up all over the place in emergency rooms and hospitals. And our good digital systems was able to contact and monitor them at home. And that was very important for keeping people out of hospital and reducing infection through unnecessary contact, physical contact with services. I'll stop there.
Okay, great. Jack Bell, with kudos first for the ungodly hour, sticking with us. You had a couple of questions, if you could pose them.
Yeah, thanks, John. I'll just read out my question just because I'm a bit tired. It's a great presentation, and I'm particularly interested because actually, I'll just see if I can. No, I can't turn my camera on. We've also published previously a model that links multiple iterative action research cycles with different implementation frameworks as well. And so it's close to my heart. I guess my question is, how do we get the balance right between just starting something and quickly picking process measures or implementation outcomes measures and then iteratively adjusting them as we fly along versus the traditional, perhaps, implementation research approach, if I can be a bit pointy, of spending a couple of years getting the context analysis exactly perfect before starting anything? That's my first question.
Thanks. Great question. I think that's exactly right. First of all, I don't think it's either or. I think we just need to do a bit more of the rapid implementation research. I'm not against the terrific work that Brian and Greg and others are doing in terms of hybrid models and the systematic. We need that. That's the science. But the second thing I would say then is that all I would say is, after that is, I think first do no harm. And I think one of the big concerns that I have is about getting the right balance between quality and speed. And if you go too fast, you may not have sufficiently accurate or valid, and you may not even know it. And you then may be presenting numbers and information as researchers to decision makers that are potentially misleading. I mean, for example, take imperial science and their early models. They were way out, way out. They certainly frightened the British government, and I think it led to them doing the right thing. But those models were just, you know, anyway. So it's about getting that balance and about recognizing that if you come from a science perspective, that practitioners and managers think either it's out of date and totally relevant, or it's very true, but it's only blindingly obvious and not terribly useful. But also that they do, you have the actual report has credibility, but usefulness doesn't have credibility. So it's about getting that balance between the need for speed and the quality, and your responsibility as researchers to be able to explain the limitations of the data so it's not misleading. The last thing I'll say is a lot of these changes are being continually adapted, and some of them may be based on already tested or tried. Question is the adaptation still effective? Now, either researchers can do that assessment, or people on the ground can do that assessment, like you tend to do with quality improvement. If people on the ground do it, it's very useful to have researchers to advise and check that the assessments they do actually give them valid feedback about the effectiveness of the adapted versions, not least things to do with have they used the right statistical process control charts, etc. I'll stop there.
Great, thank you. Greg from the photo has been listening intently. Greg, you had a question that I'm very interested in as well about funding cycles. If you could unmute and pose your question.
Sure. Thank you, John, for a great talk. And so this is multiple parts, but what are your thoughts about funding cycles and impact on the efficiency and timeliness of implementation research? For example, how do we promote quick funding to facilitate that research and feedback? And should funding mechanisms require engagement with policy and decision makers and incentivize those linkages?
Thanks, Greg. I'd love to hear your answer to that question, and Brian. So I think one advantage of the engaged or embedded is that you're already funded for other projects. And secondly, people, you can have operational budgets diverted for necessary research if they believe it's going to be necessary and useful. So I think one of the issue is there's the grant, the usual grant proposal and application approaches. And we've been lucky in Sweden in that many of the usual grant givers have invited COVID proposals. And, you know, I've put in 6 or 7 on this, and my managers in the region and elsewhere say, well, look, okay, if you've put in for these, maybe some of these will come through, but we'll cover you for what you need meanwhile. But it's not an ideal approach, and we can't always assume that all this money is going to be available for emergency research into COVID. But I do feel implementation science researchers have missed a trick in terms of pivoting to access that finance. I suppose the only other alternative would be to lobby. I think NIH and other national bodies are more now, would now be more willing to have a pot of money for that sort of emergency, flexible emergency service delivery and public health type research, because they did it in the emergency already. The question would be, well, are they going to put out pots of money for, first of all, for the winter research, and secondly, for what I've called the after, or rather the second pandemic in terms of chronic and elsewhere. For the winter type of research, we're already having grant requests and offers coming through, and there have been, I've noticed, I think it was the NIH or others, no, actually it's one of ours, we're making a lot of money available for if you need to collect data on existing projects during this period that are particularly important and useful, apply here and we will supplement funding for data gathering. So all I'm saying here, Greg, is that I think one of the things that this crisis has done is it has provoked funders and others into making finance available. The question is what happens as we go back to the new normal, that as implementation researchers, we need to pivot and show that our research will be relevant and fundable, and it gives value for money, not in 3 years' time, but actually during the next few months. But I'm very interested in what Brian and Greg's answers to that are.
So I'll offer just a couple quick comments, but we are time to transition to our final concluding remarks, as well as the all-important award. So first of all, John, let me thank you for your presentation comments. There is some additional discussion within both Q&A and chat, and I believe we'll have the ability to make that discussion available, including some useful resources and highlights of some activity that both Jack Bell, Jane Sandel, and others have been involved in. Just quickly on the last point, for us in the States, PCORI has been the model for very rapid responses, both in making funding available to supplement and modify existing projects in a very rapid manner, as well as funding for new responses. On the method side, I'll point out, especially to my colleagues in the States, that the NIH, in particular NCI, is very interested in this issue of rapid implementation research, and is doing some work both developing some guidance as well as collating examples. So I'd encourage folks to get in touch with me. With that, let me turn the floor back to Nick, if you could activate your video and audio as well for, as I said, the awards as well as concluding comments. And again, John, thank you, and thanks to those who posed questions.